Hello everyone, my name is Jen Nolan and on behalf of Musculoskeletal Australia, I'd like to warmly welcome you to our webinar this evening on the diagnosis and management of lupus. I would like to begin by acknowledging the traditional custodians of the land from which we are broadcasting this evening, the Boon Wurrung people of the Kulin Nation, and pay my respects to their elders past, present and emerging. As this is our last webinar for 2020, I'm very happy to provide you with our list of free consumer webinars for 2021. Again, we have a great and diverse list of topics ranging from a person's employment rights when working with a chronic or musculoskeletal condition to issues concerning women with rheumatoid arthritis and pregnancy, amongst several others. The registration links for our webinars will be emailed to you in the next week or so. Also, don't forget, if you have missed any of our webinars this year, you can always view the recordings on our website. When you visit our website, you'll find an extensive range of information, films and videos, apart from our other initiatives and services, such as our peer support groups, our MSK Kids program and our MSK Helpline, among many other things. Remember to contact our national MSK helpline at any time via email or phone on 1800 263 265. Our presenter for this evening is Associate Professor Alberta Hoi, who is a rheumatologist, leading lupus expert and translational researcher in Australia. Alberta is the head of the Lupus Clinic at Monash Medical Centre and chair of the Australian Lupus Registry and Biobank. She also has a position within the Department of Medicine, School of Clinical Sciences, Monash University. Her research focuses on disease predictors and outcomes, registry design and implementation, quality of care, and patient-centred interactions. Without further ado, I'll hand proceedings over to Alberta. Thanks very much, Alberta.
Thank you, Jen. And thank you for MSK Australia for inviting me to participate in this webinar. It is an absolute pleasure to take part in consumer educations, and I've done similar webinar before, and I hope this is an informative sessions for you. So, prepared my talk based on some of the common questions that I hear from patients when I talk to them around the topics of lupus. Just bear with me, there you go. So some of the key questions that get asked of me, such as why it is so hard to make a diagnosis of lupus. So I want to spend some time about how clinicians make a diagnosis based on some of the processes that we do. And then I want to cover some of the typical disease course of lupus and current practice of treatment. And then finally, some active areas of research before we move on to the questions and answer sessions. So what is systemic lupus erythematosus? Well, it's what we call a classical autoimmune disease. What that means is that it's probably one of the most well-studied disease in the scientific literature, where we understand about the different pathways, immunological pathway that can go wrong, and that lupus as a disease is a very good example of that. Typically, the disease involves chronic inflammations in different organs. So, and the examples of the typical organ involved include joints, skin, kidneys, for example, heart, brain, and so on. Even though there's quite a breadth of different organs, it doesn't mean that everyone will get the same, all of these organ involvements. In fact, some people may only have one or two of their target organ involvement. The disease is also classically described as heterogeneous, and what that means is that each individual can be very different from another. And both clinically, so how their disease manifests, as well as immunologically. So when we test them for different antibodies profile, for example, they can be quite different. But there are quite a few well-described clusters that we do understand. Now, like a lot of the autoimmune disease, the exact cause is unknown. But we do know that genetic predisposition is a big part of this. But there are characteristic triggers such as UV lights or infections or even pregnancy and hormones that can play a role. So before we understand lupus, we need to sort of go back and understand the concept of autoimmunity and what our immune system does for us. So our immune system is our primary defense, and it helps us to fight pathogens, infections, and so on. But when the immune system is not working properly, it can actually misbehave and produce reactions against yourself. So in these situations, the immune system can produce antibodies, and we call these autoantibodies, towards yourself. And there are maybe other immune cells that can cause problems, such as inflammation in a variety of organs. It is really a spectrum going from a normal person to one who has who developed an autoimmune disease. And there are many people who may show signs of autoimmunity, but may never end up developing an autoimmune disease, and for reasons we don't fully understand. It's definitely a gradations there. So in order to help you understand how clinicians make the diagnosis of lupus, I thought I'll use an analogy of gemstones, of the process where a geologist or a jeweler help to identify gemstones. And of course, you can see that there are often many different types of gemstones, and sometimes it can be very difficult to precisely identify them. And there are physical property of the mineral that we do use, such as colors and transparency, the rare refractive index, specific gravity, for example, and then other sort of more specific tests that can help us classify what stone is what. However, despite all these physical tests or physical property of the gemstone, the final determinations of what is often made by human observations combined with knowledge and their experience. So it's not really just about one test or one physical property that can make that determination. Is based on all of these factors together with the experience of the person making these identifications. So this is not different in people with autoimmune disease and in the setting of lupus. There are over 100 different types of autoimmune disease. And the way that the clinicians make the diagnosis is based on history, and what that means is the symptoms that you volunteer, and both historical symptoms as well as current symptoms. Clinical signs, so physical findings that we see, and then a variety of laboratory tests. And what the clinician aims to do is to clarify what are the target organ involved, and then consider a whole lot of mimics that can occur. And in terms of the laboratory tests, what we are looking for are presence of abnormal inflammations, either, for example, in the blood or in the joints or skin, wherever the target organ is. And we also want to clarify whether there's abnormal immune activation, so some markers or autoantibodies that can help us. And together, we call that the serological profile. So we often sort of talks about people with autoimmune disease with whichever serological profiles that they carry. So what are some of the symptoms of lupus? Well, first of all, they can be quite non-specific. So we often use this word constitutional symptoms to describe how patients can just say they feel unwell or fatigue. This can be a very early symptom, and it can persist throughout the illness. There's sometimes more serious constitutional symptoms such as fever or even weight loss, for example, but a lot of patients only have the more non-specific types. And then other symptoms may relate to the specific organ of involvement. So, for example, if it's the skin that is involved, they may have a rash. Joints, for example, they might have some stiffness or swelling or joint pain. And a mucosa, so they might have mouth ulcers or pleurisy, that lining of the lungs becomes inflamed, and that may become painful. Raynaud's phenomenon refers to a particular process where your circulation is affected. So some of these are common symptoms of lupus. There are also some what we call silent organs, and what that means is that when these organs become involved, particularly early on, they may be relatively asymptomatic, so the patient doesn't know about it, and all they feel is some non-specific constitutional symptoms, and not until it's quite severe that this manifests. So the kidneys is a good example, and certainly some of the blood count, for example, is something that only in the early stage only manifests on blood tests. But overall, it is quite variable how one person presents compared to another. So I've got a complicated slides here showing you the 2019 European and American classification criteria for lupus. And clinicians use this type of classification criteria to help us make the diagnosis of lupus. And there has been quite a few different iterations of this, and 2019 is our latest iterations. And the reason why there's so many versions is that what we're trying to do is to improve the sensitivity and specificity. So we want to reduce as many false positive and false negative diagnoses out there. So this classification has just been published and it's been accepted as a improved versions. And what you can see here is that the concept is that lupus is a multi-system autoimmune disease. So you see different boxes here that refers to what we call domains. So different areas that can go wrong in lupus. And the key changes of the 2019 classification criteria is that they have pulled together some of the previous features, and they have group them into the domains rather than the individual manifestations. And you'll see in the box there that there are numbers, and these are called weightings. So some of the numbers are higher. For example, you can see on the right-hand panel, SLE, specific autoantibody, where if you get an anti-double-stranded DNA or anti-SM antibody, you get 6 points, for example. If you have renal disease, you actually get 10 points. So you can see that this is the system that clinicians sort of work with in trying to determine how likely that the presentations may lead to the diagnosis of lupus. And you can see also with this process that sometimes it takes time for us to finally feel confident that the diagnosis of lupus can be made, because some of these manifestations may not happen all at once, and it could be present itself in a staggered way. So there are many related conditions that the patient can have when they have a suspected diagnosis of lupus. So first of all, one of a common subgroup is what we call undifferentiated connective tissue disease. And what it means is exactly that the patient hasn't really differentiated themselves into a more precise label, such as lupus. Now, there are other connective tissue disease that falls into the same sort of umbrella, conditions like Sjogren's, scleroderma, dermatomyositis. So some of them may present lupus-like, and then when we finally clarify the history and doing some tests, we might be able to say, look, this is actually not lupus, it's more likely to be Sjogren's. But certainly there are patients who remain undifferentiated for life sometimes. Now, there are other forms of lupus also less common, but certainly within our consideration. So drug-induced lupus, for example, the cause of the condition is related to a particular drug exposure. And if we can identify that, removing that drug means that the patient then will be cured. There are lupus that affects only the skin. We call that cutaneous lupus. And also importantly, there are a number of inflammatory arthritis that can mimic lupus, and they present with joint pain and then a positive ANA test. I'll come back to talk about ANA in a few slides later. But certainly patient can have rheumatoid-like or what we call spondyloarthritis that can mimic the early suspicions of lupus. And then finally, fibromyalgia can coexist in people with autoimmune disease. Fibromyalgia is a process where people get a lot of sensitizations, and they often have a lot of constitutional symptoms, fatigue, they get pain, they get quite a lot of widespread pain. And in some of these patients, they get mistaken as having an autoimmune disease. So it is important, certainly when the suspicions is raised, that you consult a rheumatologist to try to sort of clarify this using the process that I mentioned. So I will go through a little bit about the purpose of medical tests, because often that's a big part of what rheumatologists do after we hear the history. But I will also say that there is no one test that will show that you have an autoimmune disease, because often people get very worried when the general practitioner, for example, do a immune test, like a positive ANA test, and then they feel that means that they have an autoimmune disease, and that's far from the truth. That we actually required a combinations of findings before we can make such a diagnosis. So tests are very important because we do use it to confirm ambiguous symptoms. And then we use them to also look for presence of abnormal inflammation that I mentioned before. So, for example, to confirm that there is systemic inflammations by looking at some inflammatory markers, or that sometimes we may do imaging tests to look for inflammations in organs such as in the joints, or for example in the muscles. As I mentioned before, we do look for this presence of abnormal immune activations with autoantibody profile and different sort of protein, and together we call that the serological profile for the patients. We often sometimes also do tests after we make the diagnosis of lupus to clarify the extent of organ involvement. So, example of this, for example, are like your urine test, looking for the degree of protein loss in the kidney as a mark of a severity of the kidney disease. Or sometimes, for example, we do breathing tests to look at lung involvement to see how bad things are. So there are lots of tests that are organized by the specialist after the diagnosis is made. I mentioned before that I want to talk a little bit about the ANA test, or the anti-nuclear antibodies. This is probably the most well-known antibody in the community, in general practice. It's the first test that we recommend people do when they have a suspicion that the patient may have an autoimmune disease. And it's really the serological hallmark for a range of different systemic autoimmune disease, and not really specific to lupus at all. It can help us to establish the diagnosis and move one step forward in the diagnostic process. And in fact, in the 2019 criteria for lupus, we require patients to have at least a historical positive ANA test. But there's lots of problem relating to the interpretations of the test, and lots of false positive that can be found because it's such a non-specific marker of immune activations. Now, some of these false positive can occur in situations like chronic infections, things like, for example, chronic hepatitis or chronic people with bronchiectasis, for example, can have the presence of positive ANA tests. And certainly certain drugs, for example, and even common drugs like the oral contraceptive pills, for example, can be associated with a positive ANA test. So the clinician often needs to take into account of all of this before we can make an assessment whether this ANA test is significant. We also know that even if there is a presence of an autoimmune disease, it may not be lupus, as I mentioned. So it could be rheumatoid arthritis or seronegative rheumatoid arthritis. It could be a related connective tissue disease like Sjogren's, or it could be a drug-induced lupus. So it doesn't tell us specifically that this is systemic lupus. And then there are other sort of organ-specific autoimmune disease like type 1 diabetes, vitiligo, which is a skin condition, or thyroid disease that can be as commonly associated with positive ANA. So the next section is really about understanding a little bit about the disease course once we make the diagnosis of lupus. And it is frustrating. Sometimes people do worry about the disease because it can be so unpredictable. It can be quite variable from one individual to another. And I've sort of drew this graph here to sort of signify some of the fluctuations that we sometimes see. Probably I'll say the more common presentation is this sort of brownish line on the bottom, where people have some fluctuating disease activity, but not too bad with time. And then they would have some increase in disease activity. We call them flares, and that can fluctuate, depends on what, you know, either environmental factors or other sort of stresses. There are some people, so these are the people who have relatively mild disease, but in others, they may have a quite severe disease, and it could be, for example, at onset, or it could be sort of after a little bit of a grumbling start. And then, but with treatment, sometimes they can have that disease activity brought under control, and then they can remain relatively quiescent for life. And so this is that sort of beige color sort of line that I've sort of signified there. But then in a minority of the patient, they have much more severe disease, and we call them persistently active disease, where the disease activity is always high, even though there may be some fluctuations. And obviously these are the minority, but we are very eager to sort of bring to target this particular population to bring their disease under controlled. So now, so I mentioned the word flare before, and which sort of, in a sense, it means that a fluctuation or an increase of disease activity. And part of the process after the diagnosis of lupus is really working with your rheumatologist to learn how to recognize what is a flare, and that the flare is coming, and what steps to take to cope with that. And so this is really important, that you have good communications with your treating doctor, so that you can do some prompt investigations and then get on to treatment if that's the way. So what we're aiming for is disease remissions, because what we do know is that disease activity, when untreated, lead to irreversible damage and complications in the patients. So we do know that remissions is possible with the current available therapy. We now have quite a variety of immunosuppressive medications, and with appropriate use, they are very effective in controlling disease. There are a whole range of what we call adjuvant treatment to sort of help to improve particular target organs. So, for example, when you have kidney disease, you may be on in addition to your immunosuppressants, you may be on blood pressure pills, or you may be on aspirin, you may be on vitamin D, for example, to sort of help with a whole variety of different aspects of the conditions. We do know remission is really important. I mentioned before that ongoing active disease leads to that long-term irreversible damage. And so the more we are able to keep the disease in low disease activity, the better the outcome is for the patients. A few sort of quick words on lupus and pregnancy, because after all, this is a disease that affects mostly women, so 9 times more women than men are affected. It's important to note that lupus doesn't really increases your risk of infertility, except for a very small subset of patients. We call them the antiphospholipid syndrome, is a particular subset that can have pregnancy complications. But outside that, most patients can get pregnant without much interventions. But it is really important that we control the disease activity so that the outcome for the mother and the child is as best as we can. And what we want to do is aim for at least a 6 months period of quiescence before pregnancy occurs. So that would mean that you, for any pregnancy plan, for you to flag it with your treating clinician, so that we can make appropriate plans in terms of any change in your medications that is required in order to get you there. So I put down here just to summarize the different aspects that when a lupus woman come to us and talk about pregnancy, that we want to sort of think about what are the effect and consequence on the mum themselves and the pregnancy journey, and then what may happen to the baby as well. And frequently we work together with either, we work together with the obstetricians and also frequently an obstetric physicians to sort of make sure that journey is as smooth as possible. So from the rheumatologist point of view, we want to make sure, as I said, to control the disease so that it's as quiescent as possible, as quiet as possible. And then during pregnancy, there can sometimes be complications like early preeclampsia or unplanned cesarean section. These sort of things we work together with the obstetricians, together with some intensive monitoring for the babies as well. So some general advice for mom-to-be, we definitely recommend the folic acid, which I think is universally given now, that you should avoid smoking and alcohol. And some of these medications are actually quite safe during pregnancy and can be used throughout, including some of the commonly used immunosuppressants and hydroxic chloroquine or Plaquenil. I mentioned before about that 6 months period of quiescent disease before you actually try to fall pregnant. And I mentioned already about medication. So okay, so the next section is about sort of UV protections, because sunlight is such a common trigger for the disease that we, I thought I'll put a slide in here just to cover that, that 60% of lupus patients can get sun-induced rashes, and then a smaller percentage can get other sort of more serious flare relating to sun exposure. So in our Australian environment, I think we do know a lot about sun protection, but sometimes we all can be blamed for being a bit slack about it. But it is really important in the lupus populations that we do apply sunscreen. We have to be generous and frequent reapplications, and you should talk to your family practitioner or a dermatologist if you are having difficulty finding one that suits you. And there are other sort of exposure that you precautions that you can plan for example, avoiding at sort of peak UV exposure time, or even, for example, clothing is an important aspect of protecting yourself. There has been occasionally have the odd patient that asks me about fluorescent lights and whatnot. So even though theoretically there is some small amount of UV light that is emitted from fluorescent lights, it's really a very, very rare contributor to lupus flare. So I think more commonly, for example, it will be more about the UVA exposure when you're driving cars, for example, that you forget that you need to actually still put on sunscreen when you're inside the car. The UV light is thought to exacerbate disease by a number of hypothetical ways. So it can have a direct effect on damage to DNAs. It can increase the binding of these autoantibodies to the skin cells so that it can then trigger some downstream inflammatory change to the in the skin, so causing a localized skin flare. And then it can also promote this general amplifications of immune process, where there's this process we call increased apoptosis. And it's basically when the skin dies, it can expose its nuclear material to your circulation. So that's sometimes, well, is sort of the hypothesis of how a lupus patient produce antibody that react against self-nuclear material. Definitely strong exposure between sun exposure to some of the cutaneous form of lupus, so the subacute lupus erythematosus or the discoid lupus erythematosus have very strong association with sun exposure. So in here, so I've want to talk about Plaquenil, which is a treatment for cutaneous lupus that you would read on the product information that it can exacerbate photosensitivity. In some patients, they can also cause some discolorations, which is a sort of a side effects that relate to the drug if you have excessive sun exposure. Having known that, though, it means that that it doesn't mean that you shouldn't take Plaquenil. What it means is that you need to sort of protect yourself and really think about ways that you can sun protect, either using sunscreen or clothing or both. Lupus patients are already at risk of osteoporosis due to multiple risk factors, and so we do know that we get our vitamin D from the sun, and so vitamin D deficiency is very common in lupus patients, so adequate supplementation is also critical. And often a lot of the lupus patients who are on long-term immunosuppressants, they may be at risk of developing skin cancers and that sort of thing, so further reasons to avoid sun exposure and doing regular skin checks. So finally, I want to talk about some of the concept of treatment for lupus. And I've sort of grouped them into sort of three big goals of three aims. One is to manage the symptoms that patient presents. And as I said, sometimes the symptoms may be very non-specific or may not be obviously related to the target organ. But we do know that there are some organs, or we call them vital organs, that are really critical, that we don't want to risk any permanent damage to them. And so, and then also the other aspect of treatment is about preventing relapses. So preventing, you may be able to control the current disease, but what you want is to maintain that, and so that you reduce future flares. So essentially, it comes down to using appropriate anti-inflammatory medications, which are sort of first-line treatment for lupus. But when there is vital organ involvement, we probably need to use a more potent form. So often that would mean either corticosteroids, or which can be given sort of by mouth or by intravenous. There are also potent topical corticosteroids as well, and then a whole variety of immunosuppressive medications, which then can continue, and we call that maintenance immunosuppressive medications. So the most well-known one is hydroxychloroquine or Plaquenil. This is a class of medications that we sometimes call the anti-malarial because of the history of where it came from. But these days we don't use it for treatment or prevention of malaria. We have better drugs. But it's more recently has had a lot of press because of the COVID situations that is being tested for both prevention and treatment, and unfortunately for treatment and prevention for COVID, but unfortunately that hasn't been proven to be useful. But I think the world has been introduced to this very old drug that rheumatologists have used for a long time for treatments of lupus. This drug can be used alone or in combinations with other immunosuppressives, and it's very effective in treating joint pain, rashes, and sort of common organs such as the inflammation of the lung lining that I mentioned before. So sometimes patient presents with pleurisy, for example, and sometimes it's also quite helpful for the constitutional symptoms such as fatigue. It's very important as a drug to as a maintenance therapy to prevent flare in the long term. There's a whole long list of immunosuppressive. Some of you may have heard of these already. If you are patients that you are already on some of these, methotrexate, azathioprine, mycophenolate, cyclosporin, tacrolimus, and then cyclophosphamide. So in Australia, we actually have access to all of these. We're very lucky. Our government have allow us access to a lot of these medications, and we have a good PBS system where cost is not a big issue about accessing these type of medications. They really, those immunosuppressive that I've listed there before, they are used very non-specifically for lupus, and there has been a lack of drugs that are specifically approved for these conditions for a long time. So the first drug that has specifically been approved is the hydroxychloroquine, the Plaquenil that I mentioned back in 1955. And then since then, we've been borrowing a lot of the immunosuppressants that we use in other conditions and tested and used quite widely in patients with lupus. And so we do have an understanding of their efficacy, but these drugs are not specifically used for lupus itself. And it's taken a long time for new drugs to be developed, in part because of the complexity of the disease. I mentioned before that lupus is a sort of classic autoimmune conditions, but even though you would know so much about it scientifically, when we look at it clinically, it's still a very complex disease. And so that it has been a number of barriers in terms of developing drugs for these conditions. And it's taken a long time and for belimumab to be the first approved biologics for lupus back in 2011. Now, belimumab in Australia is still, unfortunately, not funded by the government. It's been approved by FDA and the TGAs, but currently it's been rejected by the PBAC twice because they feel that even though there is a clear clinical need for effective and safe treatment for lupus, they feel that with belimumab, with the studies that has been presented, there is only a modest clinical benefit in a subset of patients, and that is deemed to be not cost effective enough. And so I guess for specialists who work in this area, it's very, very frustrating. And we do appreciate, for example, a whole lot of biologic therapy that is available for other rheumatological conditions. But that's more reason for us to continue our work in sort of developing new targets and clinical trials, etc., to provide more treatment options for patients. But until then, I think what we do understand is that, yes, we already have a large number of drugs that we do have access to. We do know that in addition to just having these drugs available, having a good team involved in the management of the disease is really, really important, because often patients have many needs, and because it's such a multi-system disease, that sometimes patients may not present directly to the rheumatologist. They may present initially to, say, the dermatologist or the nephrologist or general physicians. And so often rheumatologists helps to get involved and coordinate the care with other specialists to help manage different organ-specific problems that the patient may have. So now this is, I think, my last slides, really just to highlight a few sort of active area of research that I know and I'm personally involved in, just so that you can sort of get a taste of what is happening there. As Jen mentions in the beginning, that I'm involved with the Australian Lupus Registry and Biobank. We had the finding sites at Monash, but now is a multi-site national project that we are looking at recruiting patients with full criteria lupus, and we want to follow patients long-term to determine their disease course and what are some of the predictors that make the disease better, or what are some of the predictors that may make the disease worse. And so we definitely are very interested in sort of looking at also a different sort of therapy that may be available, and looking at this interaction between the different components of the immune system, between the innate and adaptive immune system, and all the different genetic contributions as well. With the registry, we get a lot of information about medication use, and so we want to develop better ways of using some of these old drugs. And we already know, and this in the literature, for example, some of these older drug, for example, cyclophosphamide, that used to be sort of deemed as the chemo drug and very sort of for severe lupus. We now know we can use it much more safely in different protocols. For example, one called Euro Lupus protocol. Mycophenolate, for example, started off as a transplant drug and then used in lupus nephritis. But now we are very commonly using that for other non-renal indications. And Plaquenil, as I mentioned, is one of the anchor drugs. So it's one of the really important drugs that we want patients to be on, and it helps other drugs to work better as well. So it's different ways that we can use new therapy for lupus. We want to work out how to prevent long-term complications in our patients. And so one of the important aspects that we know is that lupus patient can get accelerated cardiovascular disease or heart disease in lupus patients. And then we also know a lot about steroid side effects. And unfortunately, steroid is still the mainstay of therapy for a lot of patients, especially if they can come to see a specialist unit. I see a lot of steroid being overused in the community, but we know very well the side effects profile of that, causing osteoporosis, different metabolic syndrome, and so it is our interest in trying to learn more about how to reduce these problems. And then finally, some of the ways of how to better deliver care to our patients. So in Australia, we have different models of cares. We have the public system, the private system, and then different sort of factors that can affect quality of cares. We certainly are very interested in having more patient engagement and in sort of teaching them, and part of this exercise of the webinar is to teach them about different ways that you can self-manage your disease, not solely, not by yourself altogether, but sort of be more, confident about how you can take some initial step while you wait for some guidance by your treating doctor. So without further ado, I think I've left myself about 15 minutes for some questions, and I will try to answer them as best I could. Thank you.
Thanks very much, Alberta. That was a really interesting and comprehensive presentation. And I've viewed webinars in the past, but it's always great to have the reminders about the details of what is obviously quite a very complex condition. We've got a couple of questions that have come in, and if anyone else has a question at the moment, can I suggest you type it in the question box now, just so that we have time to cover our questions and finish right on our finishing time for this evening at 8 p.m. Australian Eastern Standard Time. One question to start with, Alberta, you mentioned about how women is the predominant group that will often suffer from lupus. What is the sort of the typical age of onset with regards to lupus? I mean, mentioning pregnancy, obviously you're talking about fairly young women, but is there a sort of a typical age group where the disease might have a more common onset?
Yeah, so I think that from our registry data, that we do know that the peak onset is about sort of mid-age, so 35 to 45 sort of age group, okay? But it can certainly affect all age groups. So, and particularly even in the pediatric populations, they can suffer from lupus, and in fact, they tend to be the more severe group. Okay, it is more uncommon for the really older populations, and sometimes we get again sort of mimics that looks like lupus, but in fact it may be like a paraneoplastic process driving that. But I would say middle age is the classic presentation time.
And I always think of doctors and particularly rheumatologists as being like detectives. And you certainly sort of outlined that this evening with regards to the range of tests that must go through, and even sort of excluding other possibilities for people and their symptoms and so on. So with regards to, you mentioned GPs and how they might sometimes do an ANA test, and you said about the interpretation of that test can be problematic. Would you sort of say that most GPs are quite good at realising that there needs to be a referral to a rheumatologist? Should the the symptoms or the condition reported by the patient warrant that?
Yeah, I think it is an area that I think it still needs ongoing work, and it is quite variable from the referral that I get from general practitioner as a practicing rheumatologist. So I would say some GPs are excellent and they do understand the complexity and they do understand that the ANA itself is not a determinant. It is a bit of a fine line from someone who are not overreacting versus people who are reacting too quickly, for example. So sometimes we get a lot of referral when we sort of read the symptoms and the other sort of blood tests. So taking aside the ANA test, the other sort of commonly available tests that can be done it already give us clue that this is highly unlikely that this is lupus. And so sometimes it's certainly this interaction between patients and the GP is really important. And I have done various GP education sessions and whatnot, but I think having that discussions and with the general practitioner to sort of tease out how much he understands the process and whether or not sometimes, for example, if there's any delay in making a referral to see a rheumatologist, whether or not there are other tests that can be done to sort of weigh up the probability, it would be a useful one. I mean, in the ideal situations, yes, everyone who have a suspected diagnosis get to see a rheumatologist, but there aren't enough of us, and sometimes I do see a lot of anxiety out there when this is flagged as a possibility, and I think the thing to do is to just to have that discussions with the doctors, and sometimes there are very simple things that can be done that help us to determine that risk.
And before we move on to some other questions, your mention of self-management at the end there, I think is incredibly important, and that's one thing Musculoskeletal Australia certainly aims to promote with people is the provision of information, and we have quite comprehensive information about lupus on our website that is prepared for people with the condition. So a couple of questions: would exercise help with lupus, and if so, what type? Like, for example, high cardio or a lower level exercise?
Yeah, so I think in terms of exercise, I think there's a recent study actually to look at some very simple upper limb strengthening exercise that improve patients' well-being. Okay, so they did do it on a lupus populations, but I suspect it's not a lupus specific effect. We do know exercise play a big part in our general well-being. There are a lot of reasons why lupus patient may be less fit, and we do, for example, know that with steroid use, they can have a sort of metabolic syndrome. They may gain weight. And even fibromyalgia that I mentioned often coexist in patients with lupus, and that often impact on the patient's endurance, for example. So lots of factors there that can make people feel yuck, and the management of that is exercise. And now there is not really a specific type of exercise that they need to do. I often tell patients to find something they enjoyed. If it's something that they feel they're confident in working through, they may or may not need to engage a professional. But if, for example, if they have no idea what to do, then engaging an exercise physiologist or their physio is a good start to get them design with a program that will give them options and choices and so on. So, but any form of exercise, it can be aerobic form of exercise, strengthening work, some stretching exercise. Yeah, so they all have different benefits, but ultimately the thing that works best is something that they enjoy and that they can take part regularly. Yeah,
that's right, and they sustain.
Yes.
The role of diet in managing symptoms. What have you got to say about that, Alberta?
Yeah, that's often also very, a lot of patients are very interested in that, but there's not a lot of specific research about that in lupus. What is probably more relevant is about counteracting the metabolic effect if you're taking certain medications. So we often have a discussion when we have to put patients on hydrosteroid on how to manage their diet so that they don't have that excessive weight gain, for example, relating to that. There are a whole lot of anti-inflammatory diet out there. They generally, from my understanding, are fairly sort of healthy options anyway. So I don't discourage people to pursue those. I think that certainly they can be useful. I guess the other aspect of dietary manipulation is that sometimes patients do have a lot of intolerance, and so they may do some elimination diet. We do know, for example, full-blown celiac disease is not that commonly occur in people with lupus, but a lot of people can have gluten intolerance and that sort of thing. So I think you certainly work with a dietitian if you suspect that is the case, and when done properly and not to the extreme, it may be useful in controlling some of the local symptoms or gut symptoms and that sort of thing, but probably not a lot of direct evidence about controlling the disease overall.
Okay. And Alberta, if lupus is reasonably well controlled, how does the disease impact on people as they age?
Yeah, good question. So I think our best case scenario is to keep people with very low disease activity. And we have certainly seen a lot of people who has what we call quiescent disease for a long time, decades in our clinics, right? So then they still have their own aging issues. So their joints can still undergo wear and tear. They can still have heart disease and so on. So often the discussions then is about whether or not their prior treatment accelerate any of those things. And a lot of the time as rheumatologists, we're good general physicians, so we do understand about how to manage those things as well. So I a lot of people sort of talk about burnt out disease. It may it's not really that common phenomenon. I think that it's probably more I guess our feelings in looking at our cohort, and I've shown you that graph before about people's disease can be going to different types. So, if you belong to a group of patients who has these frequent flares, that's what you'll be. And when you age, unfortunately, you still run a risk of that. And so often we will continue some of the immunosuppressants. But you may belong to the group where you only have that early disease activity, and then it's been relatively easy to control things, and that will continue to be the case as you get older. I guess when they get really, really, really old, when other things sort of start to affect them, we do often will have to weigh up what are the benefit and risk of using immune suppressants. So we always sort of we don't want to do any harm from the medications that we use. And so, sometimes we may have to make the decision and say, look, the patient is too frail. We would have to stop some of these immunosuppressants because it's giving them too much other problems.
Yeah, thanks for that. An important question for the time. Any comments on dealing with COVID-19 while on immunosuppressive therapy? Should we worry, and how much?
Yeah, it's a really good question. And I think, in the beginning, February, March, we really didn't know. And we were sort of guided by our, the European colleagues, because they had the outbreaks there, and there's a global COVID registry for rheumatic disease patients. And so and so we rely on this early experience, and the message from our Australian rheumatology associations, which turns out to be the right message, is not to discontinue the immunosuppressants. And so we want the disease to be stable, that is much worse for the patients if they end up having a flare in this time. And so we actually uphold that advice throughout. And obviously there are some patients who are worried and they still sort of talk about reducing medications and whatnot. But overall, I find that most of my patients went through it without any issues. in Australia, I don't think we have a lupus patients who has COVID, so we're very, very lucky. But we have other rheumatic disease patients who had the disease, and some of them are on immunosuppressants, and some of, you know, they obviously many of them recover well as well. So it's certainly a process that is still ongoing. We're learning lots about the relationship between the infections and the so COVID infections and the disease and the medications and the like. But I would also say that there's a lot of analogy about how the COVID infection affects the body. The way it attacks the body is actually through immune pathways. And in fact, a lot of the treatment for severe COVID disease is using immunosuppressants. Okay, so I think, you know, we are very reassured that people shouldn't just discontinue immunosuppressants. They shouldn't just take Plaquenil or other things just for what they hear on the media, but I think they should continue taking the medications.
Yep, great. And also, is there any research to indicate that lupus can be hereditary?
Yeah, so I mentioned before that genes play a big part in determining whether you have lupus. But it's a very complex area. It's not a single gene disease. It's a polygenetic disease. So you know, you inherit some from your parents, and then there are other sort of changes that occur. We know you know, even if you have identical twins with exactly the same genetic material, your risk of lupus is only sort of 20–30%. So it's not high. So there are a lot of other external factors. So the most common question I get asked by patients with lupus is whether or not their children is going to be affected, and that risk is actually very low. The incidence or the prevalence of lupus is, you know, estimated to be about, you know, 1 in 1,000. So, you know, rare disease. And so even if your child increases that risk, it's still a very rare disease. Yeah.
Okay, we've got a couple of more questions to get through in the next few minutes. Alberta, is there any link between lupus and mixed connective tissue disorder?
Yeah.
Any suggestions about where the person can find out more about these disorders?
So mixed connective tissue disease is another connective tissue disease. And it's actually very close to lupus, and a lot of the patients with MCTD or mixed connective tissue disease would fulfill the criteria for lupus. And so, regard them as a you know, sister conditions, I would say. I think, what does MSK Australia have information? If MSK Australia doesn't have information on MCTD, check out the Rheumatology Association's page, but otherwise talk to your rheumatologist. They will be able to explain that a bit more.
And are there, I thought when you brought up the slide about research, if people, someone's asking about any current drug trials in Melbourne, how do people find out about the latest research and whether they might be, you know, might qualify to be on any of the research trials?
Yeah, so I understand Monash. So I work at Monash Health, and we do have a number of clinical trials, both for systemic lupus, and then next year we'll also have some for cutaneous lupus. I think the Emeritus research are based in Malvern. They're also recruiting patients for clinical drug trial for lupus. I think they do advertise, and so I think if you are interested, perhaps get your GP to make a referral to the Monash Lupus Clinic, and detailing what your lupus history is like. We do have a long, you know, a relatively long rating list, but often the more information your GP write down, the more helpful we are. And if they write something along the line that you're seeking for clinical drug trial, then we can have a look at the information provided and prioritize those. Yeah.
Okay, great. And also, Alberta, any opinion on having live vaccine if you have lupus?
Yeah, contraindicated if you're on certain immunosuppressants. So things like methotrexate, azathioprine, mycophenolate is not recommended. And the most common live vaccines is the shingles vaccine. So we say to avoid it. Yeah.
And one very quick question, and I know it would very much depend on personal circumstances and symptoms and so on. What sort of lifespan can a person with lupus expect, or is that just too hard to give a general response to? Does it very much depend on individual circumstances?
It certainly does depend on individuals. So we do have some population data, and that the 5-year survival rate, for example, is like 95%. But that often, considering that lupus patients can have their diagnosis in their 30s, that 95%, so that 5% don't make it in 5 years, is still pretty horrendous, and probably reflect that really small subgroup of patients who have very severe disease. So in general, we say that you should expect a normal life expectancy, unless you have very, very active disease. You know, we certainly hear a lot of sad story of lupus, you know, causing premature death in young people, but they are the minority in the uncommon situations.
We have one last question. I'm going to break my own rule and just what's the usual length from first symptoms to diagnosis?
Oh, I don't know whether I know the answers to that, because it can be a long time. It could be sort of, and a lot of it would depends on this whole thing about what caused the disease in the first place. And so, you know, we certainly know there are studies that shows that you can have antibodies for 10, 20 years before patients eventually develop the disease. There's a US Army study that shows that. So antibody itself can be present and you have autoimmunity, but there's no way in predicting who is actually going to get the disease. So it depends on when you say it's from so from the first symptoms to disease can be, we're talking about, could be, you know, weeks, months, you know, it can be very variable. So, and I guess the question is not to panic. You know, when you have the first symptoms, we can quantify the risk a little bit by doing some assessment of the full panel of, you know, how likely you are by looking at your serological profile. And if you have none of those bad factors, then, you know, nothing much may happen for a long time. You may never evolve to have the disease. Yeah.
Well, Alberta, that brings us to the end of the questions and also the end of our time this evening. I've gone a little bit over. Look, thank you so much for your generosity in giving a very comprehensive presentation and also giving great answers to all those questions that came through as well. So thank you again, Alberta. Thanks to everyone who has joined this evening.